Thank you very much. First of all, I would like to thank our distinguished guest speaker visiting our center, Professor Heather Ross, which is she's my professor and mentor when I was at the University of Toronto. Professor Hisham Dekenish. Of course, it's very difficult to speak after Sir Professor Magdi. So basically, my talk today I will be talk about device therapy in heart failure patient from the electrophysiology perspective. So I will start with this slide, which really summarizes the history of implantable defibrillator. And the first device, which was implanted in 1980s, it used to be a huge device implanted in the intra-abdominal cavities. The leads are epicardial leads. They used to have a lot of problem, inappropriate shock. Later on, as the technology got progressed, they had the transvenous leads. This was in the late 80s. However, the devices were still huge at that time, and they required to implant them in the abdominal cavity until 1993, where they started to have a smaller device, and it's implanted in the subcutaneous subpectoral, or in the subcutaneous area in the left upper chest. And basically, the history goes, the initial technology where these devices were to prevent or terminate ventricular arrhythmias or ventricular fibrillation as a shocking box, basically. Whereas the newer device, they are much more advanced now. They are not only helpful with the termination of dangerous ventricular arrhythmias, tachyarrhythmias, but also they have features for heart failure management as well, which I will be alluded to during my presentation. So this is the size of the devices, where it is really becoming quite small. So I will start with some basic concepts of implantable defibrillators for our cardiology audience here. So devices are either single chamber. What we mean is a single chamber, have a single lead in the right ventricle, or dual chamber implantable defibrillator, which has leads in the right atrium and the right ventricle. And biventricular ICD or pacemaker, they have 3 leads, 1 lead in the right atrium, 1 in the right ventricle, and the 3rd lead goes in a branch in the coronary sinus on the epicardial surface of the left ventricle. And basically, this is a cartoon, just show us where those leads sits. The atrium, the RV in the RV apex or septum, and the 3rd lead in the coronary sinus, which we like to be in the posterior or in the lateral part of the left ventricle. Basically, what ICD does is it senses for ventricular activity and reacts as it is programmed accordingly. If the device is for example, the patient is going really bradycardic, so the device will identify this. If the rate is, for example, below 50, it starts pacing at that rate. If the ICD detects a ventricular arrhythmias, it will, based to an algorithm, it will try to terminate those dangerous arrhythmias. So the ICDs in patients with heart failure, we program them into 2 zones, into VT zone, which we usually we keep the cut points between 180 to 220 beats per minute, or in the VF zone, which is more than 220 beats per minute. And basically, there are two types of therapy. One is anti-tachycardia pacing, and this is usually in the VT zone, where it tries to terminate the ventricular tachycardia without delivering a shock, and it is a painless to the patient. Whereas if the patient is in the VF zone and it is sustained for a duration of time, the device will deliver a shock to terminate the ventricular tachyarrhythmias. So the ICD batteries last for 4 to 7 years, depending on the pacing shock frequency, but the newer devices, they can last up to 10 years. Some companies are saying maybe 12 years. There is no separate battery. The whole ICD generator needs to be replaced. It is not chargeable from outside. Common things, whether shocks are felt, it depends on the level of consciousness and the hemodynamic stability during that rhythm. If the patient sustained ventricular arrhythmias and he lost consciousness and then the device give him the shock, he will most likely will not feel it. But if it's before that, then he will feel the shock, and it is quite painful. So there are some ICD misconception. ICDs are smart, they are, they do. It's not absolutely correct, They do what they are told to do. And ICD improves quality of life. It's wrong. Usually, ICD typically improves survival. However, the CRT component, which really has an impact on the quality of life. And this is the third important, where many people think ICD prevent VT or VF. Basically, this is wrong. They just get you out of it once you are in it. So who needs an implantable defibrillator? Implantable defibrillator, basically, they've fallen into two groups. We classify them as a prophylactic, as a primary, what we call them as a primary prevention. Those are most of our heart failure patients. They are high risk of sudden cardiac death, but no history of VT or VF or hemodynamically significant ventricular tachycardia. So this is one indication. The other indication is cardiac arrest survival, or who had documented VF and hemodynamically significant ventricular tachycardia. So there has been a large body of evidence and multiple trials. There are major for the prevention of sudden cardiac death. We will not go through them, but this is the one in green are some of the trials that they look at the primary prevention, and the one in yellow for the secondary prevention. And the ejection fraction are more in those are below 35%. Basically, we need to think of implantable defibrillator in patients who had survived the cardiac arrest with no reversible cause, prior MI with decreased ejection fraction of below 35%, symptomatic heart failure with low ejection fraction below 35%. Other condition, I think Prof. McKenna will also allude to the familial arrhythmic syndromes, the hypertrophic cardiomyopathies, the Brugada, the ARVD, and the long QT syndrome. So regarding quality of life in heart failure patients, in patients with implantable defibrillator, there has been multiple trials looking at this. They started looking at patients with moderate to severely symptomatic patients. They are in New York class 3 and 4. And these trials have shown superiority and effectiveness of this therapy in these patients. But we went back and asked ourselves whether we should really, whether this therapy should be given earlier on. We don't need to wait until patient in New York class 3 and 4, whether we should really go ahead. If they are even 1 to 2, so there has been trials like Made It CRT, RAFT. I was one of the fellows who took, it's a Canadian a study. So all, again, they were in favor even with early mild to moderate symptoms of heart failure. We should, if they fulfill the criteria, then they should go for CRT implantation. So this is just, this is from the European 2013, the guidelines, indication for CRT in patient in sinus rhythm, class 1. They should have left bundle with a QRS more than or equal to 150 millisecond, or 120 to 150 still are a class 1. In addition to ejection fraction below 35%, they have a New York heart class between 2 to 3 or ambulatory 4, and they should be on full medical treatment. We get a premature referral sometimes. They need to be on full medical treatment. One important thing also, we should, this doesn't work in this group. Chronic heart failure, even if they are on good optimum medical treatment, if the QRS duration less than 120 milliseconds, CRT doesn't work in this group. So let's switch gear now. We talked about prevention of sudden death by defibrillation. Our new device now, they have more sophisticated part in heart failure management and monitoring. So we do have at our center, at least we have 10 patients, which we do home monitoring for them. So what feature we are able to get from these patients? So in addition to weight and blood pressure, which we could get over from the patient himself, we could get heart rate trends, and this is important. Basically, if we are, and this we receive on a daily basis report of these patients. If we see a change in their heart rate trend, there is increasing in heart rate, this may be an alarm for us to call this patient earlier rather than leaving him later. Percentage of pacing is very important in the CRT patient. They should be more than 90% pacing. If we identify that the pacing is below 90%, we will call them earlier and try to adjust their medication. Heart rate variability, we are able to get this, and some time it will tell us whether the patient is going or having a problem with fluid overload. Patient activities, those devices now, it will tell us regarding patient activities. If there is a decrease in patient activities, it's worthwhile calling the patient and see what is going on. Respiratory rate trending. Again, if there is increase in respiratory rate, this could alert us. Presence of ventricular arrhythmias or atrial fibrillation burden. As we know, atrial fibrillation could tip heart failure very easily into a florid heart failure. So this we could pick it up from home monitoring. The transthoracic impedance, and this we have at least 50 patients, and they have an alarm. If this impedance goes up, it will, at certain time in the morning, it will beep, and the patient will come to the clinic in a day or two. We interrogate the device and we examine him clinically. This is usually an early stages of heart failure. We could increase the dose of Lasix and avoid hospitalization. So this is a cartoon how this home monitoring works. So this is the patient at home. This is the care link, or each company has a different system. So there are two ways, or it could be even wireless to the patient itself. And this is done on a daily basis. This is sent to a monitored, secure center. and then basically, and this gets transmitted back to the doctor. It could be, it goes through the emails, or it could be even going through a messaging to the doctor. We do have this capabilities here. We have around 10 of our patients. We are following them with this technology. So this is just about the OptiVol. This is also a feature of one of the implantable defibrillator. So once the patient is having heart failure, there is a more fluid retention, and there will be decrease in impedance, and the device has a sensor and is able to detect that, and it basically it will send an alarm. It will beep to the patient, and also it could, if he has a home monitoring, it will send it to our station here. So this is some of the heart failure management report of these devices. And this is the OptiVol. There is a, like if it's above 50, then the alarm will go off. And this signifies some fluid accumulation. Basically, there are more to it regarding heart rate variability, regarding, there are more reports, patients' activities. Also, we could encounter them in this report. So in conclusion, heart failure is a complex syndrome with a high morbidity and mortality. ICDs are effective for the prevention of sudden cardiac death for the primary and secondary prevention patient. CRT-induced reverse remodeling linked to reduction in heart failure related hospitalization, death, and possibly over time sudden death. All available heart failure diagnostic. I agree with all my previous speakers that the technology is advancing. I think we need to utilize those diagnostics for the better care of our patient. So all available heart failure diagnostic couples with thorough clinical assessment should be utilized in heart failure patient management. Heart failure diagnostic may be used as a tool for assessment of current heart failure status, as well as a tool for predicting impending heart failure decompensation and day-to-day management. Thank you very much. I would like to thank my group, Dr. Shahul Hamid, Dr. Sayyid, who's doing a great job in running the clinic, Dr. Qasim, Dr. Muhammad Khalil, and the nursing staff as well. Thank you very much.
Just a question, Dr. Nidal. Thank you for your lovely talk.